All right, we can go ahead and get started. I know a few more people will be joining us, but welcome everyone to Project Echo Geriatrics. Glad to have all of you joining us today. We have a great session planned. Our speaker is wonderful. I'll tell you about her in a moment. And then we'll follow up our didactic with our case discussion, which is really the heart of Echo, where we talk about a complex case altogether. And we have a geriatric specialist panel and all of you with expertise to share in the discussion of a complex case. So we'll start off with our mini didactic. Our speaker today is Kristina Cosley, who is a physical therapist based at Harborview Medical Center. She has great expertise in fall prevention and has for a while now been part of the interprofessional team at the Harborview Medical Center Fall Prevention Clinic. She also practices in outpatient physical therapy, where she also spends a lot of time continuing that work with fall prevention. Today, she's going to talk about a way to integrate fall prevention and fall risk reduction in primary care through an evidence-based toolkit. So thanks so much, Kristina, for coming to talk to us today.
Thank you, Dr. Bennett, for the introduction. I really appreciate that. As Dr. Bennett said, I am a physical therapist and I work in the Falls Clinic, which is kind of a part of senior care clinic at Harborview Medical Center. And I get the pleasure of working with some attending physicians and often residents and medical students where we see patients for comprehensive fall risk assessments. So I wanted to share with you a little bit of that experience today and also some information on the CDC's STEADI toolkit. So today we'll talk just a little bit about the burden of falls. I know that we're all very aware of this issue, mostly focusing on risk factors for falls and some tips for you to be able to implement fall prevention into your patient care visits, primarily using the CDC's STEADI toolkit. And this is a way for you to screen your patients for fall risk, assess their fall risk factors, and then offer treatment for each of those factors. And then we'll talk briefly about follow-up, and I really want to give to you a lot of ideas for the tools and resources that the CDC has to offer to help you in this journey. So we know that falls are common, and we know that every second an older adult falls. Unintentional injuries are the 7th leading cause of death in older adults, and falls are the #1 cause of those unintentional injuries. We also know that this is going to be a growing problem as our older adult population grows. And believe it or not, most patients, more than half of older patients, will not talk to their doctors about falls. You know, a lot of them feel like it's just a normal part of aging. You know, their neighbor fell, their family member fell, it might happen to them too. And also they're a little bit worried that if they say something to their family member or their doctor, that something might happen to kind of impact their independence. And the other reason is because they're really not aware that there are risk factors that they can work on and make improvements on to help reduce their fall risk factor. So fall screening is really important, and starting the process of doing some assessment and treatment can be really beneficial. The main way that we do that is by identifying the modifiable risk factors. So we know there are some risk factors that we can't change. They're age, sex, race, ethnicity, and history of falls. We're not going to be able to change that. But we are able to change a multitude of other risk factors that we're going to talk a lot more about today. So their gait, strength, or balance. Any medication, like a psychoactive medication, can increase their fall risk. Home safety issues, orthostatic hypotension, a visual impairment, issues with their feet or inappropriate footwear, vitamin D deficiency, or comorbidities like depression, incontinence, osteoporosis, and dementia can also increase fall risk. And we know that the more fall risk factors they have, the higher their risk for falling is. And conversely, if we can work on some of these fall risk factors, it will decrease their risk for falling. So to do that, I introduced to you the STEADI Toolkit, which stands for Stopping Elderly Accidents, Deaths, and Injuries. And this is from the CDC, and it's based on the American Geriatrics Society and the British Geriatrics Society clinical practice guidelines for fall prevention in older adults. And it's a really nice framework. It's organized very well to give you screening tools, assessment tools for modifiable risk factors, and then ideas for treatment for each of those risk factors. And the goal is to reduce fall-related hospitalizations, reduce healthcare costs, and the really rewarding part is, really improving the quality of life of our patients and their independence. So this is an algorithm that is from the CDC. This is part of that STEADI toolkit. And it's a lot, right? It's a lot of words. It's probably impossible for you to read right now. But what I'd like to do is just kind of take you through it step by step so that it can really become a usable tool for you. So we'll start with the screening process. And I'm sure many of you are screening your patients for falls. This isn't a new idea. So I bet a lot of you are doing this already. You want to be able to screen your patients 65 and older at least once a year, or if they actually tell you that they had a fall. And there's 2 validated screening tools that you can use. There's the 3 key questions, which we'll talk about. And then there's the CDC's Stay Independent questionnaire. So let's go through an example of using the 3 key questions. Those are, have you fallen in the last year? Do you feel unsteady when you're standing or walking? And do you worry about falling? If they answer yes to any of them, you can consider them at risk for falls and try to move towards working on assessment and treatment of those risk factors. If they answer no to all of them, as a person 65 or older, I would say they are at least a low fall risk. We know that patients 65 and older have about a 30% chance of falling. So it'd be great to be able to give them a little bit of information. Maybe you don't have to go through a whole assessment, but I'll talk to you later about a few things you could send them home with to help them thinking about fall prevention. The second screening tool would be the Stay Independent questionnaire. And this is something that the patient fills out, or perhaps their caregiver or family member if the patient has a cognitive impairment. And there's a set of yes/no questions. And for each yes, there's a numerical value. If they score 4 or higher, then they would be at risk for falls. So those are your 2 tools, pretty easy to use. When integrating screening tools, if you haven't already, you can just think about where they fit in your workflow. Maybe they're on intake paperwork that the patient would fill out by hand when they arrive, or maybe it's something they fill out electronically before they come. But definitely capturing the screening, for example, in the Welcome to Medicare exam or those Medicare annual wellness visits. Those would be a couple of examples. And if you haven't started screening yet, you could set yourself a goal and check in on how you're doing. So let's say, for example, your patient does screen at risk for falls. Ideally, you're going to go through the modifiable risk factors. Now, we know that you won't have time to go through all of these. So we're going to try to be creative on how to get some of this done. In the falls clinic, we get the luxury of the time that's the purpose of the visit. We are going through all these modifiable risk factors, but we are doing some delegating, and I'll talk to you a little bit about that. So consider which fall risk factors you might want to start working on. Consider delegating them and get through as many as you can. You can also look at these over time. They don't have to all get done in one visit. So what we're going to do in the next slide, it's very busy, but I wanted to go through these 8 main areas of fall risk factors and show you that the CDC's organized it so that you have an assessment tool for each and then an intervention for each. So I'll start with the gait, strength, and balance, since that's my area. When we see patients together in the falls clinic, I do a full PT exam and even more tests than you see here. But the idea is to take a look at their static and dynamic balance, their functional leg strength, their gait speed. And if they test at risk for falls for any of those tests, then we're going to recommend physical therapy. And at Harborview, we use a Tai Chi based program called Moving for Better Balance. And it's evidence-based and it's great and it's a lot of fun. So Tai Chi is definitely a buzzword as we talk about fall prevention. The physicians in clinic are looking at medications that may increase fall risk, and a lot of times they're communicating with the primary care providers. They're never just outright stopping things unless it's maybe a over-the-counter Benadryl or Tylenol PM or something like that. But the idea of stopping, switching, or reducing medications that could contribute to fall risk is important. And we are super lucky to have pharmacy on staff. So Carol Crawford, who's here, she helps us out a ton with that. In terms of home safety, we ask patients a lot about, do they have grab bars in the bathroom? Do they have a shower bench to sit down on or a raised toilet seat? Do they have throw rugs they could potentially trip over, or cluttered walkways, cords they're tripping over? Are they, do they keep things they need in easy to reach places, or are they climbing up on step stools? And in cases where we're worried about home safety, you can refer to occupational therapy for a home safety evaluation. And there's also a great handout I'll show you later that you can just give to the patient to get them looking, kind of room by room in their house at home safety. For orthostatic hypotension, there's clear instructions on how to measure it and treat the underlying cause. For vision impairments, we're often checking to see when the last time a patient saw their eye doctor was. And we're usually trying to talk people out of the bifocal lenses or multifocal lenses and into the single lens glasses. So when they're reading, they have their readers, and when they're walking around, or especially out in the community, they're wearing their distance lenses. And that's basically because if a patient loses their balance, their eyes are going to move faster than their head and neck. And so they're going to be looking through that reader lens, and then their feet and the ground are going to be very blurry. So that's not going to help them much if they have a loss of balance. With feet and footwear, again, a lot of times we're looking for foot deformities, decreased sensation, pain in the feet. Sometimes we get podiatry involved. And we talk a lot about footwear to our patients. So ideally, they're wearing like an athletic shoe that's supportive and well-fitting, has good traction on the bottom. And inside their house, they're either wearing that athletic shoe or maybe a slipper that covers their toe and their heel and has a nice, tread or traction on the bottom, non-slip surface. We try to get them away from wearing just socks or bare feet in the house. They can wear the socks with the grip on them though, like the hospital socks. That's okay. And then certainly there's making sure they're getting enough vitamin D, and then optimizing treatments for some of those comorbidities like osteoporosis, depression, dementia, incontinence. Here are some tools that may be useful for you if you are thinking about having some of your staff help with this process. So for instance, in our clinic, our medical assistants, who are amazing, they room the patient and they do the timed up and go test, they do the visual acuity, and then they test for orthostatic hypotension. So those are some big things on the list that really help us to get started. So these are great resources from the CDC that walks you through step-by-step how to do these tests. And some additional fact sheets here, medications that can cause falls, how pharmacists can help in this process of preventing falls. And then that last one is just talking to your patient about fall prevention. It's actually a great handout. It kind of goes through assessing where the patient is in the process of making change. And also it gives a lot of examples of things that you'll hear your patients say to you, like, I can't do it because, and it gives you some great examples of talking points to help them. This is the home safety checklist. So even if your patient doesn't test at a high fall risk, this is a great thing to send them home with. And all of these brochures can be ordered from the CDC website. They limit you to about 25 of each, and they do encourage you to consider just printing them, but they print out really nicely. Often most of them are just, if you print it on both sides of the paper, it's a one-pager. And this allows them to start thinking about how they can make their home safer to prevent a fall inside their home. Additional handouts for your patients. The Stay Independent one, that's the questionnaire for screening. The next one, Check for Safety, that's the home safety checklist you just got. The postural hypotension one is a really good one. I use this a lot with my patients, and I'll actually go through it with them. It does a really good job of describing all the symptoms that they could be feeling, so they'll identify with that, and some just basic things that they can do to start treating that. So getting enough hydration, standing up slowly, maybe pumping their feet and pumping their hand, making fists out of their hands before they get up. The next one just talks about how family and caregivers can be involved. They're a really important part of this. And then finally, what you can do to prevent falls. This would be the other thing I'd give patients, even if they're not testing at high fall risk. So I'd give them the home safety checklist and then the what you can do to prevent falls. That basically goes through 4 things. They can start, or encourages them to start an exercise program for balance and strength. Always review their medications with their healthcare providers, get their vision checked once a year, and then complete that home safety assessment, that home safety checklist. So we return back to this big algorithm full of information. And again, my goal is that hopefully you feel like we could break this down into pieces and tackle it in some ways. And when you are starting your journey of incorporating some more fall risk assessment and recommendations for treatment, it's great to think about how to follow up with your patients. So you really want to plan for a follow-up within about 30 to 90 days. In our clinic, the physicians do this awesome job of printing the after visit summary, and they'll often include some bullet points of all the risk factors that they should be working on. So that kind of becomes a to-do list. And when they come back for follow-up, you can run through that to-do list and see where they're at on it. What things have they started? Where are they at in that process? You know, what things didn't they start and why? You might learn that there's some barriers like, oh, I don't have transportation. I can't get to these PT appointments. So sometimes we're bringing in social work to help with things like that. And when you're, on this journey, just, remember that you can divide some tasks up between the desk staff, the medical assistants, providers, different kinds of providers like pharmacy and therapy, social work, and ask your staff for feedback. Try to engage patients and caregivers. I've found this to be a really important tool. And I'll often say to people, we're all going to work as a team because that is really what's going to make the patient most successful. And having somebody to help with some accountability and consistency for our older adult patients is really helpful. As you're starting this, try to pilot it before you really expand it, and always consider that regular training for staff. It helps, especially if you have got, staff turnover and things like that. It helps to provide regular training. And as you're, embarking on this endeavor, maybe think about what fall risk factors you could start with, and how that would work in your workflow, how you'll put it into the electronic medical record, how you'll bill for it, and how you'll kind of monitor the progress with it. And again, just the reminder that everyone can play a role.
And Sky will look at our pen.
I have a few more resources here for you. Again, the CDC is full of them. So go to the CDC, click in STEADI Toolkit and play around a little bit. I bet there will be some great things for you to be able to use. Oops, sorry about that. I'm just going to click through. You can check out these reference slides. And I just wanted to say thank you so much for allowing me to talk about this really important part of care that we can give. And just a plug for how rewarding it is to be able to tell patients that there are things that they can do to prevent falls. They get really, really excited. And often they're very motivated to continue to work on their independence. They realize that a fall is a huge threat to their independence. So they're very motivated to participate. But if you have questions or concerns along the way, or you want a little bit of advice, please feel free to reach out to me. And then the last slide is the evaluation slide.
Thanks so much, Kristina. That was a great presentation and really a great framework for thinking about fall prevention and the many things that we can do to reduce risk of falls. Does anyone have any questions? You can feel free to unmute, or if you can't unmute for some reason, feel free to put them in the chat.
Is there like a button, like where they press, like how do you get this to that? If you're not going to get where they're
Sarah has a question.
I do. Yeah. Hi. Thanks for that great presentation, Kristina.
Absolutely.
Yeah. And you mentioned addressing barriers and gave a nice example. I'm wondering if I'm just thinking of creating a safe home environment for folks that have a high fall risk. And I'm wondering if there's any community resources out there that can help folks ensure that their homes are safer. And if so, do you ever refer patients to community resources?
Yeah, absolutely. That's a great question. So there's always the referral to occupational therapy if you think they need a really detailed home safety assessment. I think it's just a good idea to kind of gauge where the patient's at and what kind of support and resources they have. Often family can also, be really active players in this. And then in our area, we have the King County EMS program. And that is a service where a physical therapist will go to a patient's house, assess for safety, and even sometimes be able to coordinate some minor home, not necessarily repair, but implement, like get the grab bars installed and things like that. But there are some stipulations with that. The patient has to be at high fall risk, live in King County, but not in Seattle. So we can get you some more information about that if that's a service that could be of useful for you and your patients.
We have folks on from the area agencies on aging. I wonder if they wanted to comment about fall prevention programs or resources available through the AAAs.
Yeah, this is Brianne from Southwest. We contract out with one of our local EMS providers and they actually go to the homes and do the STEADI assessment with folks in Clark County. So that's available here in Southwest Washington.
Great, and I know, the AAAs are a one-stop shop for if you call any of your area agencies on aging, they can refer you to fall prevention resources, including exercise programs, whether you're doing primary prevention or falls, or, looking for something to continue after someone's done their physical therapy.
I will also add that cost can sometimes and oftentimes is an issue, and that's something that AAAs might be able to assist with as well, as to offset some of that cost for providing things like hand bars and, toilet seats, raised toilet seats, those types of things.
Thanks, Felicia. Any other questions that folks have?
I have a question about footwear. This is Barb Harper. Sorry, squeaky voice today. Can you hear me?
Yes, we can
hear you.
Okay. I wonder if there's some information somewhere about footwear, because sometimes I worry about athletic footwear because it can catch on floors depending on where you're walking. Or maybe I've seen that with people who are walking poorly and I didn't recognize that it was a poor gait. Anyway, I'm basically asking about podiatric, is that the word, care and footwear that would be recommended given patients' problems, either with balance or shuffling or what have you, or if they need a podiatrist to look at their feet and suggest footwear, because that's actually what is causing the problem. Thank you.
Yeah, that's a good question. I know that we include a handout on footwear in the packet that the patients get. And I think you're right. There's a lot of different footwear out there. Sometimes if the sole is really thick, that's like, these Hoka shoes sometimes are really thick. That could be a tripping hazard. And I think in more extreme cases or maybe more complex cases, a podiatrist can be helpful, or an orthotist. I had a patient who had MS and he was getting all kinds of things done to his shoes to prevent him from catching his toes, especially on that really weak side. So that was a unique one for me, but I think there are some basic handouts, and then just kind of checking in individually with your patients if that basic information is appropriate for them.
Okay, thanks.
Yeah.
Any other questions? Great. Well, if it's all right with you,